Today again we are presenting a case in a way that our junior postgraduate will present within 3 minutes a case, and then we'll be having a discussion on the case and few question answer. With me is Professor Khawar Kazmi, a senior cardiologist, and we are lucky to have his comments. And this is the way to learn, to interact with seniors in your clinical practices and get their you can say a supervision about your mistakes. So you can start.
My patient is an 18-year-old male resident of Mitti, referred from Tando Mohammad Khan. He's a known case of valvular heart disease, severe MS, MR, severe AS, and mild to moderate AR. He came to us with complaints of shortness of breath, fever, and chest pain with associated with palpitations since 3 to 4 days. He came in ER with these symptoms. His ECG was done, which shows sinus tachycardia. On examination, he was vitally stable. On examination, there was bilateral creates at that time. X-ray was done that showed bilateral consolidation. An echo was done in ER to rule out any vegetations. Blood cultures were sent. There were no vegetation, so he was managed in ER on the provisional diagnosis of LRTI. He was also anemic. His SP was 5.6 at that time. 2-pin PC was transfused in ER, and he came on. Then he was shifted to ward after 3 days stay in ER. Now in ward, when he came, he was vitally stable. Chest was clear. In ECG, there was atrial fibrillation. His departmental echo was done that showed severe MS, severe MR, moderate to severe AR, and severe AS. On examination, when I examined the patient was lying comfortably on bed. His apex beat was at 6 intercostal space, midclavicular line. On palpation, on further palpation, there was a thrill on aortic region. On auscultation, there was a diastolic murmur in mitral area, systolic murmur, ejection systolic murmur in aortic area, which was radiating to carotids, and a systolic murmur in tricuspid area as well. Our plan is to do a DVR in this patient, as we will going to discuss this in heart team, and we will plan a DVR on this patient.
Okay, good. I think the first thing I say is that I would like to know that when did he had a history of rheumatic fever? So when was the first time he started having symptoms? How was he diagnosed to have valve disease, and when was that disease? Because I mean, what we are seeing here is kind of a complication of a problem. So that's the first thing which I would want.
Patient was normal.
Now we don't have the time to enter.
Yeah, I think so.
These are the things which were missing.
We should be.
So background again wasn't there.
Okay.
We started with assuming that we know everything.
So
because you started that we did echo to look for vegetation. We don't know what the patient is. So you have to give us a background, whether if he is diagnosed prior to this presentation, meaning by having rheumatic heart disease diagnosed with echo, then you have to give slight background.
Initially I did check if patient is a known case of valvular heart disease, severe
This
MS.
is not enough.
yeah, I mean that's fine, but known case means, I mean, how known?
Okay.
So when and how?
6 months he was.
Yeah, so so that has to be done.
Symptoms, then probably diagnosed with echo when, and that's the background that he's having, either mild, moderate, severe, what kind of MS he was having. Then right now again you said us to have a DVR on him without giving any echo, isn't it? You haven't mentioned anything of the echo, because even now that's the question for them. What is the stages of valvular heart disease? What is the stage of valvular heart disease important when you are mentioning a patient with valvular heart disease? A, risk factor. B, structure without symptom. Come with C and D. Yes. A or B तो हमें पता है. A is at risk of valvular heart disease. B is any disease without symptom, mild kind of disease. Yes, C and D.
So C is there is severe stenosis or severe disease with asymptomatic patient.
C1, C2.
C1.
C1 is severe asymptomatic.
Asymptomatic.
In C, then you have C1, C2. What is C1? What is C2?
And C2 is symptomatic with severe.
No.
Normally.
Yeah, very good. C1 is
With normal ejection fraction.
normal structural, no compromise on LV or RV, whatever. So he's having severe disease without symptom, without any LV compromise, because that you have to look for in your valvular heart disease. Like an MR severe without symptom, but if his EF is less than 60, this is a compromised LV. This is C2. But if his LV is more than 60 EF, this is C1. Because why it's important to know apne echo, you haven't told anything about echo, because we need to know with echo, is this patient a candidate for surgery or not, because that is going to tell us with or without symptom what is the, and that is very important when you're doing OPDs, to look for every patient's characteristics in echo, and there are different things: ejection fraction, end systolic dimension, other things, EF, all the things to decide whether your patient who's having severe, he's asymptomatic, but is he in a category where his LV is already compromised, then he's a candidate for surgery. Now what is D?
So D severe and symptomatic.
Severe, symptomatic.
Symptomatic.
It's severe, it's symptomatic. So most of the time D patients are candidate for surgery. But there is something wrong in AS patient, वो हम तफसील से discuss कर लेंगे. Is there anything?
Severe.
Okay, then I think there was kind of one little discrepancy. I mean, his initial ECG, you had said, showed sinus tachycardia, but then later on in the ward he had atrial fibrillation. It's possible. It may have a proximal AF, but I'll be re-looking at the ECG closely to see whether actually that was actually,
or there may be something wrong, because
right.
Structural heart defeat, so much so that you are trying to think of doing DVR, not have paroxysmal AF. Most of the time they have persistent AF, but still possible.
Yeah.
But will we review that ECG?
Yeah.
Is it sinus or not? Because this is causing slight discrepancy in our thought.
Yeah.
Chronic illness with structural heart disease and paroxysmal AF. Why? Let's see the ECG.
So second thing is his complaints were basically just shortness of breath.
Fever.
And fever. Okay. So the other thing which I would suggest, when you explained on examination the findings on the valvular findings, I would go in a little more detail. Here. So, think of that you don't really know what the echo shows, and you do an examination and jot down what your examination findings are and what does it suggest, and then match it with echo later on. Okay. So this is how it should be, and this is how you want to convey. So, I would be interested in whether it's a first heart sound is variable and second heart sound. You didn't say that he has a systolic murmur in the mitral area, although he has MR on echo. Right. But it wasn't in a way that you would first explain one area and then go to short area. You also said there is a murmur in tricuspid area.
That was not.
So what would you want to say with it to qualify what to address the question in my mind?
That's given idea that even in valvular and structural we can go in modules.
Yeah.
Clinical assessments, examination assessments, and echocardiographic features. Because we have to make a short cases, and then we'll be discussing on focus things.
Right.
So we'll make a plan for that. So thank you very much.